In my last video, I told you something that I don't think gets said enough, that I am frustrated with the way DCIS is managed. Not because surgeons are doing the wrong thing. Most of us are following evidence-based guidelines, but because the evidence base itself has significant gaps, as well as imaging. In this video, I want to go deeper into size and how much it actually drives the treatment decision, into one Nuys scoring system that many surgeons use and what its limitations are, into radiation, when it genuinely reduces meaningful risk and when its benefit is more marginal than it sounds, and into endocrine therapy for DCIS, the tamoxifen and aromatase inhibitor question, and where I think the evidence is more complicated and in some cases more concerning than it is often presented. This is the video for people who want the full picture. So let's get into it. Let's start with size, because it is one of the first things your surgeon will mention and one of the variables that feels most intuitive. Bigger means more dangerous. Smaller means less dangerous. That makes sense on a surface. But with DCIS, size is more complicated than that. Size tells us about the extent, how much of the duct system is involved. It influences whether a lumpectomy is technically feasible to achieve clear margins while preserving an acceptable cosmetic result. What size does not reliably tell us is biological behavior. A 2 centimeters area of low-grade DCIS may carry a lower risk of clinically meaningful progression than a 5 millimeters area of high-grade disease. Size and grade together tell a more complete story than either alone. There is also the question of how size is measured, and this is where the imaging limitations of DCIS become clinically important in a way that is not always explained to patients. Not all DCIS produces microcalcifications. And microcalcifications are what mammograms detect. They're calcium deposits left behind by dead or dying cells in the duct. But a proportion of DCIS does not make these calcifications, which means it leaves no footprint on a mammogram at all. The mammogram can be completely normal and the size of DCIS is simply invisible to it. MRI is sometimes used when mammographic assessment is uncertain, but here too DCIS has its limitations. High-grade DCIS, which is often associated with new vessels formation, enhances reliably on MRI. But low-grade DCIS, however, tends not to enhance, or enhances so subtly that it easily missed. This imperfect imaging picture has a direct surgical consequence that patients are often surprised by. Re-excision rates for DCIS are higher than for invasive breast cancer. When a surgeon removes invasive cancer, the tumor itself is visible in imaging or palpable in some cases and has a defined anatomical boundary. But DCIS often has none of these properties. It grows along ducts in a pattern that can skip, appearing in one part of the duct, absent for a few millimeters, then present again. This discontinuous skip lesion nature means that the true extent of DCIS may not be fully appreciated until the excised specimen is examined by a pathologist. And if the margins come back involved, a second operation is required. This is also why DCIS surgery aims for slightly wider margins than invasive cancer. because the skip lesion pattern means disease can sit just beyond what the imaging suggested was the edge of the abnormality. So when your surgeon discusses size, they're working from the best available evidence, but that evidence is imperfect. DCIS can be discontinuous, partially invisible on mammogram, and invisible on MRI in low-grade forms. The size on your pathology report is the most accurate measurement we have, but it is a measurement taken after the fact from a tissue that has already been removed. So when your surgeon uses size in the treatment conversation, the important follow-up questions are size in the context of what grade, what imaging modality was used, what does pathologist report say as the final size, and what were the margins? Because size alone, especially size from imaging alone, is not sufficient enough to drive recommendation for the treatment. In previous video, I introduced the Van Nuys Prognostic Index, or VNPI, as a tool your surgeon may use to guide the radiation discussion. The VNPI was developed by Melvin Silverstein at University of Southern California and was first published in 1996 and then updated in 2003 to add patient age. It combines 4 variables: tumor size, margin width, nuclear grade with presence or absence of comedonal necrosis, and the age, with each scored from 1 to 3, giving a total range of 4 to 12. So score of 4 to 6 suggests that excision alone may be sufficient as a treatment. Score of 7 to 9 suggests excision and radiation. A score of 10 to 12 points towards having a mastectomy. But this is all done after the surgery, not before. In New Zealand and Australia, the VNPI is used more consistently than in most other countries. Over 70% of DCIS cases here are managed with reference to it. In UK, that figure is less than 16%. And there, clinicians tend to rely more on individual clinical judgment and institutional protocols. But these score bands, the cutoffs 4 to 6, 7 to 9, 10 to 12, are derived from recurrence data. And this system has been applied and studied in many countries, and its ability to stratify recurrence risk has been reasonably consistent across those settings. That is its strength. But there is also a deeper question about what the VNPI is actually predicting. And it predicts local recurrence risk, the chance of DCIS or invasive cancer returning in the same breast after breast conserving surgery. But local recurrence and mortality are not the same thing. For most women with DCIS, a local recurrence after lumpectomy is a serious event that requires further treatment, but these women will not die of breast cancer as they do not have invasive disease. What I tend to say to my patients with DCIS is dangerous for your breast, but not for your life. None of this means that VNPI is not useful. It gives us surgeons and patients a structured way to talk about local recurrence risk and incorporates variables that are relevant. But it also should be used as a framework for a discussion, and its limitations are worth knowing. I want to revisit grade, not because I covered it in video 1 and 2, but because there is a dimension to the grade conversation that I have not fully addressed yet. Timing. We know that high-grade DCIS progresses faster than the low-grade. The Forget-Me-Not-2 data showed that 10-year untreated invasion risk of 30% for high-grade DCIS compared to only 9% for low-grade. But the timing of that progression matters as much as probability. For high-grade DCIS, the data suggests that roughly 50% of cases that will progress will do so within 5 years. This is the biological argument for why high-grade DCIS warrants prompt treatment, not because it's certain to progress, but because the window of opportunity to intervene before progression may be meaningfully shorter than for low-grade disease. For low-grade DCIS, the progression timeline is so extended, potentially decades, that it introduces the question of whether progression would even occur within women's expected lifespan, particularly in older patients. This is the biological underpinning of the active surveillance argument, and the White Comet trial restricted eligibility to grade 1 and grade 2 disease. And we talked about it in video 2, and I will link that in the area above. The practical implication is that urgency of the treatment conversation genuinely differs by grade. High-grade DCIS is not a medical emergency in traditional sense, but you still have weeks, not hours. But it is a diagnosis where delay of months rather than weeks is worth discussing with your surgeon. Low-grade DCIS, particularly in older women, affords considerably more time to make a considered decision, and in some cases, more time than we have historically assumed. Radiation after lumpectomy reduces the relative risk of local recurrence by approximately 50%. That sounds substantial, and it is. But relative risk reduction can be misleading if you don't know what it is relative to. So if your baseline recurrence risk without radiation is 30%, a 50% relative reduction brings it to 15%, which is meaningful absolute benefit of 15%. If your baseline risk is 10%, the same 50% relative risk reduction brings it to 5%, which is an absolute benefit of only 5 percentage points. It's the same relative number, but very different clinical significance. 30 to 15 people versus 10 to 5. And this is the heart of radiation question for DCIS. For high-grade DCIS with close margins, the baseline recurrence risk is high enough that radiation delivers a meaningful absolute benefit. But for low-grade disease with wide margins in an older woman, the baseline risk may be low enough that the absolute benefit of radiation is modest, potentially 3 to 5 percentage points over 10 years, while the side effects and logistical burden of radiation are the same regardless. And Van Nuys' scoring system is trying to predict these benefits. The ARTOC 9804 trial looks specifically at low-risk DCIS, which was screen-detected low to intermediate grade, under 2.5 centimeters, with margins of at least 3 millimeters. At 15 years, the rate of ipsilateral breast events was 15% without radiation and 7% with radiation. That's the real difference. But it also means that 85 out of 100 women in no radiation group were free of recurrence at 15 years. I wish we knew which 15% of women would recur. So when radiation is discussed for your DCIS, the question to ask is not just whether radiation reduces recurrence, because it does. The question is by how much for my specific grade, size, and margin width. What is my absolute risk reduction, not just my relative risk reduction? And this is a much better number that tells you how much you personally stand to gain from radiation. Now, this is a part of the video that I find most difficult to talk about clearly and most important to talk about honestly. As I mentioned in video 3, in countries where hormone receptor testing of DCIS is routine, we're talking primarily about USA and UK, women with ER-positive DCIS may be offered tamoxifen or aromatase inhibitor after surgery, with or without radiation. The rationale is that by suppressing estrogen signaling, these drugs reduce the risk of developing invasive breast cancer in either breast. And as said in that same video, in New Zealand and Australia, this is not standard practice for DCIS. And the reason for that is worth understanding. Let me start with what the evidence shows. The NSA BP B24 trial, I have no idea why they give them these names, published in 1999, showed that tamoxifen after lumpectomy and radiation for DCIS reduced the rate of breast cancer events at 5 years from 13.4% to 8.2%, a relative reduction of around 37%, and an absolute reduction of around 5 percentage points. And this was the trial that established tamoxifen as an option for ER-positive DCIS in the US. But these numbers do not tell you what happens to women who take tamoxifen for 5 years in terms of quality of life. Tamoxifen in pre- and postmenopausal women causes menopausal symptoms. Hot flushes, joint pains, mood changes, vaginal dryness, sexual dysfunction, brain fog. And these are real, persistent, and in some women, very severe. Aromatase inhibitors, which are used in postmenopausal women only, carry risk of bone density loss, osteoporosis, fracture, and cardiovascular events. And these are not trivial side effects. They accumulate over 5 years. And we're using them for a non-invasive cancer. The cancer that does not kill women. And we're using it to stop events of possibly another cancer or DCIS developing. And here is the number that I think is most important in this conversation. The absolute risk reduction in all-cause mortality from tamoxifen for DCIS is not clearly established. What we know is that it reduces breast cancer events, but we do not have strong evidence that reduces breast cancer death specifically from DCIS. In part because the mortality from DCIS is already extremely low, making a mortality benefit hard to demonstrate statistically. What this means clinically is that we may be adding a meaningful morbidity, which means side effects, 5 years of it, and maybe forever, for a treatment whose benefit is primarily measured in event reduction rather than mortality reduction, which means in reducing another breast cancer from happening or another DCIS for developing in that breast rather than risk of dying from DCIS. And there is another separate question that is emerging in literature around endocrine therapy and DCIS. If a proportion of DCIS would never have progressed regardless of treatment, then endocrine therapy in those women is not reducing their risk of future invasive cancer. It is exposing them to 5 years of side effects for no benefit. But the challenge is that we still cannot reliably identify those women, which means that a lot of women currently taking tamoxifen for DCIS may be doing it unnecessarily. I want to be clear about what I'm not saying. I'm not saying that endocrine therapy for DCIS is wrong. For some women, particularly younger women with high-grade ER-positive disease and significant family history, the benefit to risk calculation may be in favor of endocrine treatment. But what I'm trying to say is that decision should never be automatic. It should be informed, individualized conversation that includes the absolute numbers, the side effect profile, and an acknowledgement of what the evidence does and does not show. So the fact that endocrine therapy for DCIS is not routine here does not mean New Zealand and Australian surgeons are behind the evidence. It reflects a considered clinical position that the benefit to risk ratio for this specific indication has not clearly been established. So that's why in New Zealand and Australia we are not recommending tamoxifen, but it is entirely appropriate to ask why and to ask what the absolute benefit is estimated to be for your specific case. So DCIS is not a simple diagnosis. Size matters. Grade matters. The VNPI is useful, but it's a framework, not a formula. Radiation reduces recurrence, but the absolute benefit varies enormously depending on your baseline risk. And endocrine therapy may help some women, but the absolute recurrence benefit from each component of DCIS treatment varies considerably depending on the grade, size, and margin status, and that variation is worth understanding before decisions are made. What I want you to take from this video is not to doubt. I want to give you knowledge for you to learn about what questions to ask, what numbers actually matter, and what the evidence does and does not support. In my next video, I'm going to turn to intersection of DCIS and menopause. Because for women who have had a history of DCIS and have developed significant menopausal symptoms and are not on endocrine therapy, the question emerges, can you start taking hormone replacement therapy? What does the evidence actually say about HRT and breast cancer risk in a context of prior DCIS diagnosis? And that video is coming soon. So subscribe so you don't miss it. And if this video raised questions about your own treatment plan, please take those questions to your surgeon. You deserve answers, not just reassurance. Bye for now.